the roadmap that has been created through the STAR project. And we will be reflecting on more newer innovations, recent innovations in research and implementation that have been implemented over the last 3 years. So I'm handing over now to my co-chair, Heather Ingold. Heather Ingold is program manager at Unitaid, and she has been the portfolio manager for the STAR project since the beginning, since 8 years. So I have the honor to introduce her, and she will be introducing our presenters. Over to Heather.
Thank you, Karen. It has indeed been a pleasure working together. I have the absolute pleasure to introduce Dr. Rachel Bagley from WHO headquarters in Geneva, Switzerland, who will speak about the value and contribution of self-care and self-testing interventions within health systems. Over you to Rachel.
Thank you very, very much. And today is a real day of celebration. This has been a huge journey. And I do want to recognize Liz and Karen and Heather, who have worked tirelessly on self-testing. You couldn't really believe where we were 10 years ago. It was a dream, and now it's a massive reality. So I'm going to talk a little bit about how WHO, next slide please, thinks about, next slide please. It's quite difficult, this room, looking to where you can see the slides. But I just wanted to say, WHO has really come on board, not only in the HIV, STI, and hepatitis world, which I live in, but right across WHO. We really think that the self-care movement is going to change everything. As we move on over the next decade, it's going to be so much more important. People feel empowered, it's more convenient for people, and it takes time off the healthcare system. And self-testing is absolutely key to this. Self-testing and also self-sampling. Next slide. So this has been a journey for us at WHO. We've looked at HIV self-testing. That was our very first WHO recommendation. And I can tell you that was a struggle. We had a lot of opposition from people to say, there's no way people can do this. People are, it was a bit like in the early days of treatment. How are people really going to manage to take treatment effectively? And we had criticism from communities to say people will need all the counselling. There's no way they can do this. We had criticism from providers to say there's no way that people can do this. We need really fully trained healthcare workers. But hey ho, STAR gave us all that evidence to show that not only could people do HIV self-testing perfectly well, if not better, than providers. There'd be many less problems with mixing up results because you actually had your own HIV test, and then you could make choices. And again, this was a real worry. Would people do the right thing? And of course, people do the right thing. People do the right thing for their own health. They will link to further testing to confirm that result. They will link to treatment. They will think about prevention options. Maybe not today, but they will much, much more quickly than the counterfactual, which is not having access to testing. So we were really thrilled that that STAR could give us all this information, and then we could support a WHO recommendation for self-testing. And that recommendation for self-testing took many years, a huge amount of effort, many studies from the STAR countries, but we got there in the end. We worked with the manufacturer. Initially there was one, now there are several, to produce very high quality self-tests and instructions for use. And now, of course, self-testing, it's unfortunately not ubiquitous, but in many of the STAR countries and many other countries, it's really become a core part of testing. We then followed with HCV self-testing. We recognize there's a huge need to diagnose people with HCV. And we could really kickstart that progress based on a lot of that evidence from HIV. It didn't take us those enormous numbers of years and the huge amount of studies that we could use that evidence to support the HCV self-testing. And this again is going to be a great way to support much greater access for hepatitis C testing, particularly in communities that have very low diagnosis. And of course, they can be linked to curative treatment. So it's very, very exciting. And that process took us about 3 years. Then came COVID. And as you all know, it was really the same tests that we had for HIV that now could be, the same method. No one knew what a lateral flow test was until COVID came, and I'm sure every single person in this room, lateral flow test comes off the tip of their tongue really easily. Grandmothers know it. Grandmothers can do self-tests. It was a real revolution to kickstart that. And again, there weren't trials, there weren't usability studies to the same extent there had been with HIV self-testing, but those could be got out into communities and had a huge benefit to allow people to use that test to help them make decisions about what to do if they had COVID or not. And then, and my colleague has just walked into the room, Myvi, she has again used this work based on the evidence from HIV and hepatitis C to rapidly provide the guidance we have now on a recommendation for syphilis self-testing. What we need is a product. And we're really hoping manufacturers will step up on this. We know there's a massive need for increased access to syphilis testing, and that would be a huge benefit if people could do self-testing. And we know, of course, there's a dual HIV syphilis test, and again, there's no reason why that could not be a self-test. And in the future, we need self-tests for chlamydia and gonorrhea. It's the number of undiagnosed infections for treatable STIs are huge. We use largely syndromic management. It would really help the STI field to have cheap, rapid tests that could eventually be self-tests. So this will come, and I hope the next time we meet, we will really make some progress across those fields. Next slide. Is the next slide? Oh yeah. So as I said, the previous one. So as I said, we've learned from HIV self-testing. When we re-looked at our guidelines, there were 32 randomized controlled trials on self-testing, hundreds of values and preferences on self-testing, really saying that people found this empowering, they could do it, and they would prefer this to other methods right across populations, young people, old people, people from key populations across all geographies. There have been many support tools and approaches developed by STAR. We also worried about how we're going to monitor all of this, how we're going to tell what people do. And I think we've come to a place now when we recognize that we really don't need to do a lot of monitoring of self-testing. The most important thing is we get it to people and we get it to the right people. So if we're going to do any monitoring, we want to make sure that the tests get to the populations that will benefit best. Just again, I'm told I'm at time now. I think really just to say across all the self-tests that they're really important to, there are very many common issues. Feasibility, we know these are all feasible. We know that we've got to have them ethically. We can't have people using them to coerce people into testing. They're highly acceptable. They're very empowering. But we need proper messages about the need to confirm these tests. HIV, a single HIV test does not confirm you have HIV. You need to have that checked, and that's the same often with other self-tests. But there may be differences. There may be very different populations we need to support for the various self-tests. And the sample type may be different. Again, this was an issue with COVID. Of course, that was a nasal swab or an oral swab. And for chlamydia and gonorrhea, that's going to be a vaginal or urethral swab. But these problems, I think, are minor. I think we're really on the road to having a wide and increasing availability of self-tests, which will really help close some of these gaps and improve the healthcare journey for many people.
Thank you, Rachel. That was wonderful. And in your opening remarks, I know you thanked me, Karen and Liz, but it's also important that we thank you and Cheryl Johnson, who I know couldn't be here today. Without the good collaboration and everything from WHO, it's been really essential. I would like to introduce now our next speaker, Dina Resch, who will speak about self-testing and PrEP, digital and artificial intelligence solutions to increase access to testing and HIV prevention services.
Great. Thanks so much, Rachel. I think you set this up really well in terms of how far we've come. But all the time we're thinking about innovation. We're thinking about how do we take the services closer to people? How do we make it more convenient? And how do we monitor some of the quality and use of these tools? So this presentation will cover many of those questions. Next. So just to frame it up, rapid test and lateral flow testing is a huge part of global health, with billions of tests being procured, used in a variety of locations, and monitoring of these, the ease of use and the access to these are ever more important. Next. In a testing-related environment, I think one of the key areas that we focused on, we can move to the next slide. So I think, in the ecosystem, a digital health ecosystem, we talk about on the start of the slide some of the access points for testing. And you'll see the middle one, if we move next, is self-care and self-testing, and how that links then to a digital tool and to different insights that can be drawn from surveillance, from telehealth type solutions, and from quality. Next slide. Next. Great. So what do we build? We build a solution called Health Pulse AI, and really it comprises of three big components that could assist in this journey. The first relates to quality digital instructions. So we know that with testing and with self-care specifically, we have the large paper inserts. How do we bring those instructions in a simplified and easy to use way to people's cell phones as we move forward? The second is using artificial intelligence to capture the image and the test results and to double check, quality assure, and validate that it was interpreted correctly. So the user would still interpret the test results, but in the instance of a mistake or an error, the health program would be flagged and someone could reach out and correct any misadministration or misinterpretation. The third part, which is more nascent, which I don't cover here, but is the use of large language models and AI, which can assist with counseling and direction and guidance related to that test. And importantly, the technological components that help this to integrate with existing platforms. We don't want another app in the marketplace. People's phones are full. We want to be able to scale this through something like WhatsApp or apps that people already have that you can use to understand your test, use your test, and link it. Next slide. So this is the pathway that, together with STAR, PSI, and others, has been outlined related to self-testing and the acquisition of the test and how can we use technology to create awareness about where to get the test. Joining up to a chatbot driven by WhatsApp to administer and guide the test. The actual self-test administration and digital guidance through a phone. Interpreting and capturing the results using computer vision-based AI, which recognizes which test was used and what the outcome was. And then importantly, all the healthcare reminders that go with that, and if the test is positive, important prompts to link to care. Next slide. So these images show some of those features. So you can see the first one shows some of the simple step-by-step instructions accessible through the STAR WhatsApp chatbot. The augmented AI photo capture. So an important part of what we'll discuss is taking a high quality picture, and the AI runs in the background. And when you do digitize it, will only allow you to, once the AI is confirmed that the picture quality is strong. And when we talk about telehealth and access to PrEP, that becomes important. And finally, the AI for decision support that in a telehealth model is provided to the clinician making the decision from a remote location. And again, I'll go into those in more detail in just a minute. Next. So these are images of some of the workflow within the STAR PSI chatbot, and you'll see it starts with back and forth in terms of information and a registration process. It then moves to the second step, which is the administration instructions. There's tools embedded around timing and waiting the correct amount of time and notifying you, when to interpret and when to add what. Finally, the photo capture and image quality assurance I mentioned is the fourth block. The guided self-test interpretation, so the chatbot guides you into understanding what the lines mean, and then linking that to next steps and local guidance. All that data with the correct consent flows into data dashboards for understanding the data that comes from self-test journeys. Rachel mentioned COVID, and sadly during COVID, one of the big kind of unexplained or data gaps was related to self-test use in many countries and settings. Next. So I mentioned this as well previously, the linkage to care element is important. In many countries, we still have gaps from especially positive self-test results and understanding if patients are linking. So through these tools and through LLMs of the future, we are really looking at what prompts and what engagement can happen next to improve the linkage components, both to prevention options that are customized, as well as to access options and treatments. Next. So here we have three use cases that have been implemented. So the first describes the buy a test from a pharmacy. You learn about the chatbot, the guided self-test administration, and this is using private sector channels to increase uptake of self-testing and guidance. The red indicates the AI verified result, and then you get through the same chatbot your guidance, follow-up, reminders, and all of that data flowing to the Ministry of Health in real time to dashboards. The second is an interesting concept and idea piloted in a few settings, also in pharmacies, where you can do your self-test at home, run through your instructions, digitize your results, and the high quality picture, along with the AI interpretation, goes to a clinical officer or nurse provider. They sit in a call center and have the image, the AI interpretation, and a cropped, zoomed read of the read window and lines. With that, double check, they make a call, this is a negative test, let me dispense PEP or PrEP. If it's a positive test, of course, they look at how to link. So we refer to this as teleprep, and it's having some interesting and good results so far. The last bucket is an idea which we're looking to launch with a country soon, but it relates to the same type of model, but when you test and once it's verified as negative, you receive a code to access your medication from an e-locker. So right now we have e-lockers as a regular part of ARV access. Could we use them in a validated way with a chatbot and AI to collect PrEP, at least PrEP refills? Next. So finally, a little bit of data from these various models I just described. You may ask, how does the AI perform on this ePrEP telehealth journey? And the first big area is AI quality assurance. The AI correctly identifies 45% of positives that clinicians missed. So in this pharmacy model, if a clinician makes a mistake, and we've got a data set that talks to this, the clinician and AI have to agree before the PrEP can be dispensed. And with very faint lines on photos, we do find that clinicians occasionally make mistakes, and AI does a good job of picking these up. The second talks about the quality of the picture. So if you are testing from a remote location, you need a high quality photo for that teleconsult. The AI filter ensures that that picture quality is strong. And then finally, the AI is achieving rates of 96% in terms of its interpretation accuracy, which is comparable to humans, and for faint lines is actually better. I think that is the last slide. Let's just check. Great. Thanks.
Thank you, Dino. That was an excellent presentation. Next, we have Victor Adepoju from Japaigo, Nigeria, who will present on introducing and scaling up hepatitis C self-testing in Nigeria.
Oh, thank you very much for the opportunity to share some of our work on a study to assess the acceptability, feasibility, and cost of hepatitis C self-testing among key populations, as well as ART clinics in Nigeria. Next slide. So the study is being implemented in about 5 countries. Next slide. So it's just telling us different use cases for those different countries. All of them are providing facility-based distribution. In Cameroon, they distribute among community-based distribution, including through outreach programs, and second distribution among injector workers. And in India, they also did the same thing. But India is also using the virtual platforms and online distribution. While in Nigeria, like I mentioned, we distribute among key population one-stop shop, including people who inject drugs, MSM, sex workers, either positive or negative, as well as across 2 ART clinics. In South Africa, it's also similar. While in Vietnam, they use other use cases. Next slide. So what are the preliminary results from this implementation? The study has a sample size of 2,000. So for Nigeria, in terms of epidemiology, the prevalence of viral hepatitis C is 1.1%. That's about 2.4 million of the population. However, there are differences across subnational entities. For instance, the state where we're having the study, the prevalence of hepatitis C is 14%. That's 1 out of every 6. Next slide. So like I said, the study sample is 2,000, and we have both oral self-testing kit from Oral Quick and then the blood-based from PMC for research use only. And we are prioritizing people living with HIV in 2 ART clinics. And then we have also 2 one-stop shops where we are distributing among people who inject drugs, MSM, and sex workers. This health facility have experience distributing HIV self-testing in the past. We have all the ARB approvals. Next slide. So in terms of results, what did we learn from this? The uptake generally was higher, of course, among male than female. For the positivity, what we are also seeing is increasing positivity as you go across age group, as age increases. And that's also consistent from what the findings was as well in Cameroon, especially those that were born before 1960. You can see among 50 plus, the prevalence is about 23.5%, and the younger population is about between 1.5% to 7%. And that's also telling us which population we should prioritize. Overall, in the study, right now, the study overall possibility is about 12%. However, it's still higher among PLHIV in the ART clinic compared to the one-stop shop. Next slide. So for the OSS, we also, this is like the uptake among different population. Possibility among KP, like I said before, about 10% among sex worker, which is the highest, followed by the MSM, which is about 6.1%. For people who inject, there's about 7.3%. And that also validates what we are told by this study site before we started the study. Some of the pilot testing they did in the past actually shows that they have higher figures among the sex worker compared to the PWID. And for cascade of PWID, we also tested partners of those who inject drugs, which are very few in this study because most of the PWIDs actually came with their partners in most cases. But the study protocol was supposed to give the index HCV positive PWID the kit to really be able to give to the partners as well. Next slide. So in terms of outcomes and linkage, excitingly, we have about 215 people who are self-tested as positive out of the 2,000. I think at that time, our sample was still around 1,800 or thereabouts. And about 90% of them were actually linked to confirmatory PCR. And that is because we have very good infrastructure for diagnosis in Nasarawa State, where the GeneSpam machine have been optimized to be able to do RNA PCR. So that made it very easy, especially for the 2 ART clinic who have embedded GeneSpam machine. And for the OSS, there's a established and spoke model to move the samples to the GeneSpam site. Of course, we have about 80% of people who are viremic, from confirmatory RNA PCR. 90% of them were linked to direct-acting antivirus. Next slide. So we also asked questions on feasibility of the self-testing kit, and it's interesting that 65%, about 55% of people actually went for the blood-based for the blood-based kit, and about 44% went. There was higher preference for blood, and people preferred that for different reasons. And then about 43% also worked for unobserved, because patients have the choice to either do it in the presence of the observer, the trained observer at the facility, or take it home to do it themselves. But it's interesting when we ask them how would they like to use it in the future. 72% actually said they will use it unobserved in the future, which also builds the need emphasize the need for confidence building, actually when people are using it for the first time. We also asked them where they would like to use it in the future, and about 62% also said they would like to use it at home in the future. Next slide. So for acceptability, more than 95% of the participants also said that they find the self-testing kit easy to use, and they're able to interpret the results, and then also able to follow the instruction. The instructions were quite good. Because the IFU is still like a visual demonstration, we also built a local video that can actually guide people on how to go about step by step the self-testing, and that was also very useful. Next slide. So in terms of key learnings for us, it's important to leverage on the existing system, because a very good diagnostic network in Nasarawa State, where the GeneSpar machine have been optimized, and we have at least a GeneSpar machine in each district. So it was really easy for us. We have 90% of people were linked to confirmatory testing, more than 95% were linked to direct-acting drug. And our primary cohort evaluation shows after 3 months, about 92% have actually completed the DAs for our June and July cohort of patients. It's also important to engage the stakeholders, the Ministry of Health at national level, as well as the Nasarawa State Ministry of Health. We engage other partners like China, who are currently already working on ground to be able to leverage all these resources and engage the stakeholders. Of course, the WHO has said the way to go is decentralization, integration, and task shifting. So we train medical officers from these 4 sites to be able to manage hepatitis C septic. And good enough, we just have about 8 to 10 cases of advanced cirrhosis that we have to really refer to specialists. The other patients in the study were actually managed by these medical officers that have been trained, as well as nurses in this study site. There's also a need for collaboration. Giving patients the choice to make the choice between oral and blood-based is also very important. Most of the people that went for blood said they went for it because they feel it's more accurate. And since hepatitis C is being transmitted in the blood, they believe that the perception is that it's going to be more accurate and reliable. Also, there's a need for feedback mechanism. We have clinical mentorship that really go to the site from time to time to supervise what they are doing and review their data and be able to provide feedback to the health facility as well as the Ministry of Health. Thank you very much. And just to acknowledge our partner, the STAR Consortium, the Unitaid, who give us money to be able to do this work, World Health Organization, who provide technical assistance from time to time, the Ministry of Health from Nasarawa State, as well as the national, the civil society organization, the healthcare worker, and the patient. Thank you.
Thank you very much, Victor. It was an excellent presentation and nice to see the learnings from Nigeria, including building off HIV self-testing distribution. It's the same person, as you said often, so thank you for that. Our next presenter is Yasmin Dunkley from London School of Hygiene and Tropical Medicine, who will present lessons learned from COVID-19 self-testing. I hope you're seeing a pattern moving through the different diseases in Nigeria, Zimbabwe, and Malawi, as well as speak a little bit about pandemic preparedness.
Thank you so much. And it's a privilege to be here today presenting at ICASA on behalf of the stakeholders and partners on this slide and many of the colleagues who are here in the room today. So thank you. Next slide. So our colleague, Dr. Rachel Bagley, has already introduced the self-care agenda and described how this really developed within the sexual and reproductive health sector. COVID-19 has given a renewed focus and a renewed interest on self-testing in and for health emergencies. And this also aligns with our broader WHO goals of better protecting 1 billion more people from health emergencies. The research agenda for self-care interventions has been defined broadly into two groups. How can we best develop self-care interventions, and how can we best deliver self-care interventions? In terms of self-testing for COVID-19, the development of interventions includes optimizing testing interventions alongside and with the marginalized and vulnerable communities that we seek to serve. And the delivery of interventions is around the different service delivery models, many of which you've heard presented here today with other disease areas. Next slide. So what was the context of COVID-19 testing in the continent? It won't be a surprise to many of you that it was a disproportionate number of tests that were conducted in low and lower middle income countries relative to our proportion of the global population. Next slide. And this reflects not only the challenge in the volume of testing that was conducted, but also real challenges in the number of tests that were reported. Next slide. Against this backdrop, we developed and designed the 3ACP research agenda, and that stands for the Africa, Asia, Americas COVID-19 Preparedness Research Project. Through this work, we delivered over 100,000 professional use tests and over 40,000 self-tests across 7 countries, 5 of which were here in sub-Saharan Africa. Next slide. Through trying to reach diverse target populations, using different and differentiated service delivery models from diverse in-country and cross-country settings, we set out to answer these questions: how best to develop and how best to deliver self-testing interventions within a health emergency. Next slide. Those delivery models changed. As the pandemic changed and priorities changed, we had to respond, and that was particularly resonant with the arrival of the Omicron variant. We moved away from outbreak investigation and testing people at travel points and points of entry as regulations changed. And instead, we reprioritized and refocused on delivery models that looked at integration within existing health services, including primary care, outpatient departments, and within sexual and reproductive health services. And we also refocused on private sector models, including community pharmacies, patent medicine stores in Nigeria, and workplaces across all of our different contexts. Next slide. So what did we learn? Next slide, please. In terms of the development of self-testing interventions, next slide. We learned that custom interventions can be designed and co-developed by the vulnerable populations that we are seeking to serve. For example, here in Zimbabwe, our partners at SESHA developed a self-care severe COVID-19 disease monitoring system for sex workers that involved distributing pulse oximeters and food packages in the community, which was highly acceptable for sex workers testing positive with COVID-19 in this setting. In Nigeria, we were able to develop a serial self-testing workplace intervention that had incredibly high adherence, despite finding 0 positives during a period of very low disease transmission. We were also able to develop tailored digital tools that were fit for purpose to capture this programmatic data that we so severely needed on the continent. Next slide. In terms of the delivery of self-testing interventions, integration is key, not only for the normalization of COVID-19 and self-testing services more generally, but also to ensure cost effectiveness from a provider perspective. The private sector and pharmacies, as we know, are viable methods of delivering self-test kits, and that remains the same within a health emergency with COVID-19. And if we move to the next slide, whenever self-testing was offered alongside professional use testing, self-testing was always overwhelmingly preferred. Next slide. We didn't only set out to answer these research questions, but we also set out to achieve policy level and regulatory change across our different contexts. In Nigeria, Zimbabwe, and Malawi, we were able to import for research purposes 3 distinct different self-test kits for COVID-19. And in Nigeria and Zimbabwe, we also now have national self-testing policy that was explicitly dictated by the research outcomes of this 3ACP-STAR project. Next slide. However, there were, of course, challenges that we experienced with this, and that can be reflected in the far slower rollout of self-testing compared to professional use testing in our contexts. The regulatory frameworks for self-testing within a health emergency were incompletely tested by the time we experienced the COVID-19 pandemic. That was exacerbated by the fact this was a novel disease using novel testing technologies that weren't registered elsewhere, although were highly used and widely used in high-income settings and did have WHO emergency use listing. There was no regional authorization body that would enable manufacturers to bypass individual markets, and our market share as individual countries in reality was far smaller than some of the high-income settings, so perhaps we're not a priority. WHO policy was quick, but it was also slow in pandemic terms. It was 2 years in until we had WHO interim policy guidance on self-testing, through which we could have advocated for national policy on self-testing as well. And the monitoring and evaluation systems for COVID-19 self-testing were delayed, perhaps better being developed alongside in real time our professional use systems. So to conclude with the final slide, there was a strong preference for COVID-19 self-testing in this health emergency. These interventions were easy to co-develop with the most vulnerable populations. Our established HIV self-testing delivery models, hepatitis C self-testing delivery models could be leveraged for COVID-19 self-testing as well. However, our monitoring and evaluation tools were not fit for purpose, and the whole process from ethics to policy to regulatory approval was not well streamlined and too slow to usefully support self-testing at the earlier stages of this pandemic. Going forward, we recommend a 360-degree comprehensive health system review as part of pandemic preparedness. Let's put self-testing there as we consider how to move forward to learn the lessons from this pandemic so we can leverage and optimize the gains afforded by self-testing. And to conclude with the final slide, I'd just like to thank all of my colleagues here in the room and also make a plug for some of the work that they've done that's here being demonstrated as posters, including 2 pieces on the costing of this work. Thank you so much for your time.
Thank you very much, Yasmin. That was a very important presentation, and I think it really helps solidify that self-testing and self-care is the future. And I'm hoping that if there are manufacturers in the room, that you're getting the message also, and that you make self-test kits as soon as possible. I want to thank our presenters, Rachel, Victor, Dino, and Yasmin. Ask you 4 of you to step down kindly and ask our panel to come up. And I hand it back over to my co-chair, Dr. Karen Hatzold.
I'm just waiting for the panelists. Can you just please come up? Thank you. We have a distinctive team of panelists that have all been contributing to the STAR achievements. So we want to get some from those contributions now. I call upon, we will start with Ms. Noble from the Ministry of Health and Childcare in Zimbabwe as our first panelist to respond to some of my questions. Gertrude, we have been together for a very long time. I think Zimbabwe was, from the early adopter countries, the earliest of the adopter countries, and the Minister of Health in Zimbabwe launched STAR 8 years ago. You have been an extreme leader and very good leader on self-testing, even before STAR was initiated. What is your message with regards to putting policy in place for self-testing in Zimbabwe? And that has actually also followed even with COVID-19 self-testing, by the way. What can you tell to other ministries of health and how to tackle this, how we get policy in place very quickly on self-testing in their countries that would then also support the scale-up of self-testing? Over to you.
Thank you so much, Karen, and thank you to everyone, and thanks for being invited to be one of the panelists. As you have already alluded to, our Zimbabwe was one of the first countries as part of the STAR project, Zimbabwe, Malawi, and Zambia. So what I can say, why Zimbabwe, we actually recognize the potential benefits of HIV self-testing, especially when we were looking at our data, and then we realized that there were other pockets of our subpopulation which were not reaching when it comes to HIV testing. So as when the STAR was launched, what we did as a country, we actually came up with a technical working group. I know the STAR project was actually looking at maybe SESHA and PSI implementing the HIV self-testing. But what we did was we come up with a technical working group which composed of all our implementing and funding partners, as well as our regulators on when it comes to HIV self-testing, as well as the people who are living with HIV, as well as the men and other civil society who were actually part of which were actually part of our technical working group, so that we decide together. I remember when we were coming up with the instructions for use, we actually came together with all those people looking at what is it supposed to be looking like. And I remember when it even came to the who is going to be the community-based distributor, we actually sat together to come up with the criteria. So I think the strong partnership with all the stakeholders was critical in us to come up with a policy as soon as possible, because we're all on the same page on the issues of HIV self-testing. And then the other people whom were involved, which were critical, were the parliamentarians for the buy-in, for the political buy-in, as well as actually when we are disseminating the services, they will actually be able there to be helping us in the dissemination of the services. And with that, we were able to come up with the guidelines even before the WHO guidelines. We were able to say together, how should we implement HIV self-testing? And these were actually the guidelines which were used when we were actually recruiting people for distribution. And within those guidelines, we actually said, where should our distributors be? How should we distribute HIV self-testing? We actually came up together to say it has to be at the community, at the areas, community-based, facility-based, workplace, private sector distribution as well as the marketplace. We actually used even to mobilize people for the VMMC using the HIV self-testing. So it was agreement within those stakeholders to say, where do we need most? So maybe just to conclude, to say with that, we're actually able, when we had all the guidelines, we were actually able, now when WHO had come up with the guidelines, we were able actually to have that policy and all that. And we reached, especially with the parliamentarians, there was a time we were actually called to parliament with my boss, who is there, Dr. Mkurungi, to explain what is all this self-testing all about. But when we explained to them with the buy-in, they were able to take it up. And in the areas where we're not even doing HIV self-testing, they were now asking, when are you bringing self-testing into our communities? Thank you.
Thank you so much, Gertrude. Yeah, Zimbabwe had HIV self-testing policy just after WHO launched self-testing policy. So first country really. Thank you so much, Gertrude. And I think you might be excused. I know that you have to go to the airport. You're excused from the panel. Thank you so much. My next question goes to Professor Liz Corbett, Malawi School of Hygiene and Tropical Medicine. Liz, lead researcher on STAR for HIV self-testing, also then for COVID-19 self-testing. What are sort of the major lessons learned and the major outcomes of that research and from the research agenda, and how we have translated research into implementation and scale up? Okay.
Thank you so much, Karen. So it's a little bit like asking me to choose my favorite child. We've been working on self-testing together since 2015. Well, since 2013, we've been working towards it with funding since 2015 together. I mean, overall, the simple, it's so empowering, it's so strongly preferred. it enables, novel distribution, decentralized distribution models that really are such a game changer. So that is the takeaway, I would say. Now, getting there at the speed we have done, that really reflects the overall leadership of the whole consortium, and the fact that we were able to get, a good duration of fundings, long enough from Unitaid, from Gates as well, sufficient funding, and with the really huge input from Rachel, to move research, implementation, policy, and regulation just in lockstep, and that was what made it such a wonderful experience, and allowed us to move so quickly so far. The manufacturers, when we first started, really had no guidance. There was no system for them even to apply for self-testing products to be authorized by WHO. And I do think that we've seen, that's a really important area. And we've seen from Yasmin's presentation, health systems, regulatory systems, they were not set up with self-testing in mind. And when you're trying to kind of retrofit, the cracks really show. I do think we still have work to do in that. But I also think Dino's presentation has showed us so clearly that digital technology and support tools for patients as well as for clients as well as for health workers, again, I think they can be a game changer. So I think my most important outcome is really looking to the future. Just this demand is huge. It has to be managed. I think costing is essential to guide efficiency. And digital tools are going to be essential, but thought of really from the patient perspective. So we need real client-centered tools to guide and manage that huge demand. We're no longer struggling to generate demand, but rather to be most cost-effective and to have the most rational use, ensuring linkage and good patient outcomes. And just my very final point, I think even with the COVID work, HIV testing is so simple because the tests are so easy to interpret and they are so sensitive and so specific. So anything, as soon as you're into a more difficult disease, there again, the decision support tools that you need, I think, will be much more critical. Thank you.
Thanks so much, Liz. Wonderful. Again, a researcher, Euphemia Sibanda, leading the research for Susresha here in Zimbabwe. And specifically, your work was based on access to self-testing for sex workers and testing the approaches with your sex worker network. What can you say specifically to this key population and how we have reached them with self-testing and the different approaches that we use and the models that we used here? Thank you.
Yeah, thank you, Karen. Among sex workers, the model that we implemented mostly was clinic-based distribution at the national KP program clinics, where sex workers who came to the clinic were given the option to use a self-test or be tested by a provider. And we found that one of the key learnings, one of our key observations with self-testing among the sex workers is the high feasibility and acceptability of the intervention and the remarkable ability to correctly use self-tests and correctly interpret the results, which we found was even better among sex workers compared to what we saw in the general populations. And speaking to the self-care agenda that WHO is driving, as Rachel was saying, it is a key opportunity that we have sex workers who are able to self-test, they embrace this intervention, and which means there is great opportunity for STI testing and other self-care interventions that we might want to implement among sex workers. And one of the things that we also learned was the fact that use of self-test was associated with increase in uptake of testing because the opportunities to test were greater, particularly in busy clinics where health workers have a lot to do. We find that sex workers, self-testing is freeing up opportunities to do other things by health workers, so they're better able to ensure that they're testing. We found with COVID-19, where everyone who was coming was being screened and those who needed to test were offered testing. Before self-testing came, it was difficult for health workers to ensure that everyone got the testing, but we found that as self-testing came, more and more people were able to get the service. Yasmin has already talked about the ability of sex workers to also self-monitor themselves at home for disease progression after COVID-19 testing, which we also found a very good opportunity for future self-care interventions among sex workers. Thank you.
Thanks. Excellent. We're going now to actually a beneficiary or somebody who has used self-test and have benefited from the self-test, both for HIV self-testing and COVID-19 self-testing. So my next question actually goes to Mbikai Charity Matsivai, who is a representative of a community of sex workers who has used self-testing. What can you say about your experience with self-testing, and how can you see the benefits for your community and the future of self-testing in this community? Thank you.
Thank you. Good afternoon, everyone. I'm Mbikai. I'm a sex worker and a microplanner. I once used the self-test, and honestly speaking, when I used the self-test, I just used it out of fun. I just wanted to check the accuracy of the self-test. And to my surprise, the results that came after 20 minutes of waiting was the same results that came out of the blood test from my previous test at the local clinic. So that built my confidence, and also I also had the courage to distribute the test kits into the community. The test kits have got a lot of benefits to the community. It empowers the community to know their status, because they can be found at any place and at any given time. It also reduces the spread of HIV, and it also reduces the spread of HIV to others. The self-test kit also reduced the mortality and morbidity rates in the community. It also enables those who are unwilling or who are unable to reach the clinics to have their tests. This self-test also helps to reduce the non-AIDS related diseases. Thank you.
Excellent. Thank you, Jody. Any call to action, what people need to put in place, policymakers, to make self-testing available everywhere? Any call to action from your part? Any call to action for policymakers and countries to adopt self-testing to make it available everywhere for the community to benefit? Any call to action? Do you want to call action to provide self-testing through many, many outlets?
I think the providers must just keep on providing the self-test to as many as they can to the community, because the community are very much willing to use the self-test.
Thanks very much. To our last panelist, quick question as well to our Cyprian Tendo Mugondo from PAS in Uganda. Uganda has been also one of really success stories in implementation of self-testing and actually registration of several self-test kits, not only oral fluid tests, but also very rapidly registering blood-based HIV self-test kits and scaling it up through many, many models. What can you speak about specifically the private sector model? PAS was supporting the Ministry of Health in integrating self-testing in the private sector. What can you speak about? Can you speak about the successes? Can you speak about the steps that were taken to rapidly include it there and the variety of self-test kits actually in the private sector market?
Thank you very much. I'm speaking on behalf of SARS-3 consortium that implemented HIV self-testing in Uganda. What I can say about the success, I can talk about numbers, but the success of this distribution model goes beyond numbers. For example, more than 7,000 people accessed HIV self-tests through the private sector. While the test was free, people need to pay something like $1 to access their services on private model. $1 may be small money, but it's 3,000 Uganda shilling. It means a lot. It means people were able to access themselves the risk and willing to pay that money. And the results talk by themselves. 6.5% yield. It means that model was efficient. And as it was a pilot and for a small period, only implemented in Wakiso, Mukono, and Kampala district, this shows that when convenient services are implemented, and they can allow to reach people who wouldn't seek services on traditional services and can be efficient. So this also opens doors for priceless possibilities for self-care on contexts on a setting where we have less resources and time when we'll need more and more to provide client-centered services. Thank you.
Thank you very much, and thank you very much to the panelists and to the presenters from the previous round. I think we are over time with this session, but thank you very much for all your attention. Thanks for all your contributions.
Just want to thank all of our presenters and all of the STAR colleagues that are also in the room, current and former, some that have moved on since the countries have transitioned, but just to also thank you, Karen. As the donor at Unitaid, we've invested well over 100 million in self-testing for HIV, hepatitis, and COVID-19. And this consortium was massive. It included over 15 countries, I think, distributed in advance of 5 million self-tests over the last 8 years. It has led to guidelines from WHO, as Rachel said, for HIV, hepatitis, COVID-19, forthcoming syphilis, hopefully looking at maybe forthcoming other STI self-testing guidelines. And it's just been absolutely incredible. And I want to thank all of you who have contributed, all of your hard work. And yeah, I don't want it to end. So let's see what else we can do. Thank you all so much for staying too.